let's move on to lens dislocation. So this is from Ekin et al. In 2013. So you're going to have your lens, which is basically a biconcave or round hyperechoic structure, which is going to be displaced from its normal position, so either anteriorly or posteriorly. With eye movement, it might move around to see the surrounding structures, and you might have other evidence of trauma, so vitreous hemorrhage, globe rupture, retinal detachments, depending on what's going on. So A, B, and C, as you can see, they're all showing the lens dislocation. What this is doing is that they're actually moving the eyes in different locations and showing you that the lens is moving. So here it is. As you can see, it's like this little circle, exactly what you would expect to see if you turn the lens on its side. Sorry. Again, circle moving and moving in different locations. So they're all in different locations, so it was mobile within the globe. This was a case reported of a 49-year-old female in the emergency department who had blunt trauma to her left eye and acute vision loss. Unilateral mydriasis and no pupil response with hyphema, and hyphema was her physical findings. So the ultrasound by an emergency medicine physician was able to see, as you can see on the screen, so they knew exactly what it was, ectopia lentis, and this was the first case diagnosed by ultrasound in the literature. So ultrasound can help you with traumatic lens dislocations because if you see it, you don't necessarily need a CT or an MRI. So it's a possible alternative in the emergency department. So there's lots of cases, 4 case reports. Since we've already talked about Ekin, I won't go into it again. Basically, the other 3 are case reports, again, of 3 other cases. The lens dislocation was seen by point-of-care ultrasound. Of note, in one of them, the CT was actually negative. So in the Boniface et al. 2015 in the Journal of Emergency Medicine, the CT was negative, but the ultrasound showed lens dislocation. So let's move on to globe rupture. So this is, like I said, supposed to be your contraindication, although there are images out there that show globe rupture. So if you're going to ultrasound it, and I'm not recommending that you do not put any pressure on this eye. As you can see, this does not look like a normal eye. Well, use a sterile gel and a probe cover. So what you're going to see if you did ultrasound it, and again, I'm not recommending that you do, is that you're going to have decrease in the size of the chamber. So it's really hard to even see where the chamber would be from. So the chamber looks a lot smaller. You're going to have anterior chamber collapse, which we can't see in this one very well, but I'll show you in the next. Bulking of the sclera, so everything is coming up. And abnormal shape of the globe in the posterior chamber. This is obviously not a normal shape. And a large vitreous hemorrhages, which is what we're seeing right here. Here's another picture of it. So this is where you're seeing the anterior chamber is, and there's this vitreous hemorrhage echogenic material in the posterior chamber. So very obviously not a normal eye. Let's move on to leukocoria. So here is an example of what retinoblastoma will look like on ultrasound. It's this moderately echogenic, so gray, heterogeneous soft tissue mass with varying degrees of internal calcifications within some echogenic foci within it. In children less than 3 years old, an intraocular mass with calcifications is strongly suggestive of retinoblastoma, so about 91%. The importance of doing the ultrasound is so leukocoria, about 50% will have retinoblastoma from lots of different causes. So it can help differentiate what your actual leukocoria cause is. So you can see very obviously if there's a retinoblastoma there. If not, then the differential is, there's other things you can see. You could see cataracts as well, but it's just less obvious than the retinoblastoma being there.
I like the arrow in that slide.
Yeah.
That points to the entire occupying the entire globe.
Yeah, so actually I didn't go through that, so it's a good idea. So anterior chamber, this would be your posterior chamber. There's a very obvious mass sitting in the center with the arrow sign and the little calcifications of the echogenic foci within. So in terms of literature, there's only one case report that I could find from emergency medicine. So this is actually from MP's Emerge Care of a 30-month-old male in Haiti who presents to the emergency department. He's actually had symptoms for a long time, but had not been properly diagnosed. And it was very challenging to assess this child because he was to cooperate with the exam. So the POCUS did show bilateral ocular masses with dense calcifications, which again was pathognomonic retinoblastoma, and actually had a large right anechoic fluid in the retinal bulbar space, which CT and ophtho confirmed. This was pretty extensive at the time. So there isn't much out there about finding retinoblastoma. I generally find it in reports talking about things you can look for, but there isn't very much specifically looking at ultrasounds, like papers dedicated to this. There are other things, other cases out there, so case reports about other conditions that can be associated with leukocoria, so cataracts, Coats disease. I'm not of them, but they are out there. Let's move on to the swollen eye. So if you have this either from infection or from trauma, this big swollen eye that's very challenging to assess, and you're going to have to pry open, how can you assess extraocular movements and pupillary reflex? So as you can see here, the eye is moving around. So you can see the optic nerve moving from left to right. So you're seeing your ocular movements. You can assess that there is good movement there. So in the transverse plane, look left to right. In the longitudinal plane, look up and down. And if you have asymmetric globe movement or inability to move in a direction, then you might have an entrapped extraocular muscle. Or you might have pain caused by an orbital cellulitis. In terms of looking here, we're looking at the pupillary response. So as you can all see, there's a big circle here. And again, this is not mine. This is stolen from or borrowed from ALIEM. So pupil, and it constricts. So you know your pupillary response is intact. So the way that you do this, it's much easier if your eye is big and swollen because you have this big, lovely field that's filled with fluid that you can actually see much better. So you want to place a linear probe inferior to the eye and angle it superior towards the head. Or you can go from above and look down. Or you can go from the side. Doesn't matter. But either way you want to be, you're not looking the way you normally do straight on. You're looking kind of more perpendicular, no. What's the word?
The swelling.
Looking like a flush to the face. So you want to find your optic nerve, your lens, and then you want to find your iris. And if you have the other eye open and you shine the light into the other eye, you're going to see the concentric reflex and you're going to be able to see pupil constriction. If you don't, that would be a concerning feature. Does that make sense? Mm-hmm. So is there literature? Yes, there is. So in the American Journal of Emergency Medicine, 2009, so actually a little while ago, they had a case report of a 29-year-old male in the emergency department who had periocular swelling after a blunt head injury. And they were able to describe this exact thing, so the extraocular movements and pupillary reflex, in addition to doing other tests. So the reason this is helpful is, we talked about this before the talk, is that conventional exam, when you have a big swollen eye, is so challenging. There's risk of vitreous extrusion if you have a globe perforation, you didn't know that you had it. It's very painful, it's difficult. You have people or paper clips to pry this eye open. And maybe you're going to cause more damage than if you just gently put a probe on